Good morning, everybody, and welcome back to the Journal Club. We are delighted that all of you are joining us today. Today, we're discussing a very important and topical topic about bleeding risk for high bleeding patients after PCI. Today's presenter is Alessandro Beneduce from San Raffaele in Milano, and I'm delighted and a warm welcome to Professor Marco Valgimigli, who's joining us, who was the first author of this publication and a true expert in this field. So thank you very much, Prof, for joining us. Alessandro, if you'd like to start, and we can get started. If anybody has any questions during the presentation or indeed after, please type them in the chat and we will address them as soon as we can. Okay, let's go.
Okay, good morning, dear friends and colleagues. Thank you very much for being here. It's a pleasure and a privilege to have Professor Valgimigli here with us today to discuss about the MASTER DAPT trial. So let me briefly go into the topic. So balancing the complex interplay between ischemic and bleeding risk is one of the major challenges in patients undergoing PCI. As we can see from temporal trends of ischemic and bleeding risk in a high-risk setting, such as ST elevation in my patients, we see that both these risks reduce over time, and this reflects probably the implementation of strong antithrombotic strategies, as well as technological improvement in stent devices and platforms. Anyway, we need to consider that impact the relationship between bleeding events and adverse outcomes is at least as much important as that of myocardial infarction. Therefore, it is crucial to promptly target bleeding risk while maintaining optimal antithrombotic efficiency. When we think about the bleeding avoiding strategies, we need to think about these strategies as a comprehensive approach, including different interventions that can be performed at different steps before, during, and after PCI. And one of the most important things to realize is that high bleeding risk patients represent 30 to 40% of patients coming to our cath lab every day. So this is a fairly highly prevalent population. Therefore, we need to identify these patients properly, and these ARC-HBR criteria can inform clinicians and help with a valid tool to identify these patients, and this has been recently implemented besides the traditional risk scores. These criteria have been used to derive a trade-off model that can be used to derive information in individual patients and guide the tailored approach to the DAPT duration, balancing the ischemic and bleeding risk of each patient. If we look at current evidence, so we can basically summarize the DAPT strategies for high bleeding risk patients as strategies which are based on dropping the P2Y12 inhibitor, strategies based on dropping aspirin, and strategies of de-escalation. Another important initiative from the ARC-HBR is the definition of standards for trials in high bleeding risk patients. And it is very important, the distinction between trials of devices and trials of drugs. We can see that currently the evidence for high bleeding risk patients is mainly based on device trials, which have investigated DES, different DES, and compared them with BMS, other DES, or objective performance goals on the background of short DAPT. But these studies may inform stent selection, but anyway, these studies cannot inform practice with respect to optimal DAPT duration in HBR patients. On the other hand, short versus standard DAPT studies have mainly been limited to single-arm registries comparing DES with historical cohorts if we exclude the OAC trials. And these studies obviously don't have a control group, and this limits the generalizability of the studies and their impact on clinical practice. Therefore, in this complex landscape, the MASTER DAPT trial led by Professor Valgimigli and Peter Smith came as the first randomized clinical trials investigating the duration of DAPT in high bleeding risk patients beyond the indication for oral anticoagulation. In this trial, patients at high bleeding risk undergoing PCI with the MASTER DES platform for either CCS or ACS, in whom no further revascularization was planned, were included and underwent a short course of 1 month DAPT, after which they were evaluated again, and only those patients who did not experience any recurrent ischemic event or who were not actively bleeding at the moment of the re-evaluation were randomized to either a short course of DAPT, meaning dropping one of between aspirin or P2Y12 inhibitor and continuing with the standard of care treatment, or a standard antiplatelet therapy of at least 2 to 5 months according to the necessity to indication for oral anticoagulation. Patients were deemed at high bleeding risk if one of the following criteria was present, including either clinical criteria and the precise DAPT score. The MASTER DES was selected as a study device because at the moment of the trial design, this stand already had a CE mark for a short DAPT derived from the results of the Discovery 123 OCT study, in which the strut coverage was almost 85% at 1 month. If we go into the details of the DAPT regimens, we can see that these vary according to the OAC status of the patients. And if we compare this with the current recommendation from the ESC guidelines, we can see that DAPT duration in the MASTER DAPT trial has been slightly longer than what is currently recommended. So the trial was designed to have 3 primary composite endpoints to be tested in a hierarchical order. First of all, the NACE, net adverse clinical events, including all-cause death, MI, stroke, and major bleedings by means of BARC type 3 or 5, were tested for non-inferiority in the per-protocol population. After, the major adverse cardiac and cerebral events, MACE, composite of all-cause death, MI, stroke, were tested again for non-inferiority in the per-protocol population. And finally, major bleeding or clinically relevant non-major bleeding were tested actually for superiority in the intention to treat population. Overall, a large number of patients was included in the study. And finally, 4,579 patients were actually randomized to receive the abbreviated DAPT or standard DAPT, and the clinical outcomes were almost complete for all these patients at 1 year follow-up. If we look at the clinical characteristics, we can see that these are mainly 76-year-old male patients with a slightly high prevalence of diabetes, prior MI, prior PCI, chronic kidney disease, and oral anticoagulation, need for oral anticoagulation. Mainly, roughly, these patients, 50% of these patients have been included in the trial with a ACS at presentation. What is interesting to notice is that each of these patients had at least 2 high bleeding risk criteria, which are mainly represented by age, DAPT score, and OAC. But if we look at the percentage of patients being included in the study only for age or OAC, we can see that this is fairly low. Regarding the procedural characteristics, the vast majority of these patients underwent PCI through a radial approach. The prevalence of multivessel intervention, left main PCI, and complex lesion treatment was fairly high. And the total of 1.7 stents per patient, meaning more than 6,500 stents implanted overall in the study. Adherence to the DAPT regimen was very high, and this is a good point. The median DAPT duration for the index coronary intervention was 34 days in the short DAPT and 193 days in the standard DAPT. And if we look at the type of single antiplatelet therapy in the abbreviated DAPT group, we can see that P2Y12 inhibitor is slightly prevalent, with the clopidogrel being the most represented drug, and only a slight proportion of patients receiving Procedural. The primary endpoint of NACE occurred in 7.5% of patients in the abbreviated DAPT group and 7.7% in the standard DAPT group, and the non-inferiority margin was met. However, if we go into the details of this data, we can see that observed event rates were lower than expected. However, these data are anyway reassuring as the upper confidence interval is still below the recalculated non-inferiority margin. Looking at the MACE, this endpoint occurred in 6.1% of patients in the abbreviated DAPT group and in 5.9% of patients in the standard DAPT group. Again, the non-inferiority was met, and the same consideration we did before for non-inferiority testing apply here to MACE. Looking at the last endpoint, major or clinically relevant non-major bleeding occurred in 6.5% in the abbreviated DAPT group and 9.4% in the standard DAPT group. In this case, the superiority was met. Looking at the secondary outcomes, we can see that in the abbreviated DAPT group, death, cardiovascular death, cerebrovascular accident, stroke were lower, numerically lower than in the standard DAPT group, while on the other hand, there was a numerically higher rate of MI in the abbreviated DAPT group. Another thing that is interesting to notice is that the difference in the third endpoint was mainly driven by PARC2 bleedings. So in conclusion, the MASTER DAPT trial shows that in high bleeding risk patients undergoing PCI with the Ultimaster DES, a short course of 1 month of DAPT therapy was not inferior to a standard DAPT therapy with respect to net adverse clinical events, MACE, and was superior with respect to reduction in major bleeding. Of course, this study had some limitation. The open label design, DAPT duration was heterogeneous in standard DAPT group. As, DAPT duration in both arms was longer than currently recommended for ROC patients, as we saw before. Non-inferiority margins were also relatively wide, and the observed event rates were lower than expected for both NACE and MACE. The study was not designed to assess the role of single antiplatelet therapy type after DAPT discontinuation, and these results may not apply to patients treated with other DES. Now, I would like to give some perspectives, and in order to start to stimulate the discussion, I would like to ask Professor Valgimigli whether we could talk about differences between OAC versus non-OAC population in this trial, and how to reconcile the study result with current evidence favoring a very short DAPT in OAC patients, and how to deal with the signals of increasing ischemic events in these trials. And finally, in which patients considering a prolonged DAPT and which drug to choose in your opinion. Thank you.
Great. Thank you very much, Alessandro, for a very nice presentation and to start off the discussion. Professor Valgimigli, if I can invite you in, please. We can perhaps start the discussion with the points that Alessandro has raised.
Sure. Thank you very much for inviting me, and good morning, everybody. So it would be nice if you keep showing the points that I need to discuss. That would be a good roadmap for me. The first point is differences between OAC and non-OAC patients. Well, first we need to realize that the study was actually implementing two completely different treatments, both in the control and experimental arms in patients with and without OAC. So in reality, MASTER DAPT is a nested study, including OAC and non-OAC patients who were supposed to be treated differently. Perhaps as additional clarification point, we were not just investigating a 1 month DAPT versus a more prolonged regimen. We were also investigating the discontinuation of concomitant antiplatelet therapy after 6 months in OAC patients as compared to a continuation of DAPT in combination with OAC. That is unique in this study, and that needs to be emphasized. The guidelines were already opening the door for that treatment approach, yet based on consensus opinion. There has not been one single study randomizing patients to stop DAPT from the time frame of 6 months onwards. When we have broken down the primary endpoints into OAC versus non-OAC, for which randomization was stratified importantly, Formally, we can say that the study results remained consistent, meaning there was no interaction, formal interaction being reached for any of the three primary endpoints. However, there was a signal for the third primary endpoint, suggesting possible interaction, so that formally the p-value for interaction was 0.06, so not significant yet, borderline. And that interaction was suggesting a bleeding benefit among non-OAC patients and not much bleeding benefit among OAC patients. That is what we saw. If you look into the bleeding endpoint, which drove the superiority for bleeding in the overall study, namely BARC2 instead of BARC3 or 5, then interaction became highly significant. The p-value for interaction was 0.02, again suggesting that there was a remarkable benefit among non-OAC patients and perhaps little so among patients with OAC. Now, we have investigated this topic extensively, and now I can share with you that if you correct for non-adherence, that signal goes completely away. Let me clarify this point. We were asking investigators in the OAC patients who have been allocated to abbreviated DPT arm, as I was telling you before, to stop concomitant SAPT after 6 months. Unfortunately, we have registered during the study conduct a huge attrition and resistance from investigators to do so, especially from one country, if I have to be honest, especially from France. They were extremely worried about this treatment approach. And in more than 20% of patients, that approach has not been implemented, namely SAPT has been continued in the experimental arm. If you look into OAC patients allocated to abbreviated DPT, 25% of patients did not adhere to protocol mandated regimen and continue SAPT throughout. If you apply a sophisticated methodology to correct for this lack of adherence, which is the so-called G methods, which is extremely complicated because it takes into account not only pre-randomization factors, but also post-randomization factors. So it's a truly developed multivariable model, and you correct for non-adherence, and you pretend as if all patients had adhered to the study as the protocol mandated the regimen. Then you see that this interaction goes away and the bleeding benefit is consistent in both patients with and without OAC. Telling you that actually the fact that you discontinue SAPT after 6 months is really driving the bleeding benefit among OAC patients. Not much benefit within the first 6 months, if anything, because in the first 6 months, we compared 1 month EPT versus 3 months EPT in OAC patients. So the gradient between the two arms was relatively limited and small. If you correct for non-adherence after 6 months, then you see the bleeding benefit that you would have expected without any trade-off of ischemic events. So even if not the primary result, yet the adherence corrected result of MASTER DAPT is truly supporting the concept that you should stop concomitant SAPT after 6 months stent implantation and let the patient be on OAC monotherapy, which is very important findings because that is a confirmation of guidelines, yet this time based on some data, not just based on opinions. The second point, Alessandro, you listed, can you show the slide to me?
Yes, it was how to reconcile these results with the novel OAC trials.
That's a good one. That's a good one because we have been heavily criticized at all possible levels regarding the DAPT regimen that the MASTER DAPT has implemented actually in both study groups. The criticism was in both study groups, DAPT is far too long and much longer than what is currently recommended by guidelines, which is true. The guidelines now have taken a very clear-cut position by indicating roughly 1 week of triple therapy as a routine approach, which can be extended up to 1 month in highly selected patients in whom the ischemic risk would outweigh the bleeding risk. While this recommendation from guidelines is understandable, this recommendation does not entirely reflect the evidence, though. Because if you look into these 4 DOAC studies, and if you put these 4 studies together, or you do a different exercise, you just look into the most informative one, which is the Augusto study, you do see that there is a clear increase of stent thrombosis in the first 30 days by dropping aspirin very shortly after stent implantation. And that was the rationale for us to say, look, 1 week of DAPT, if you continue with clopidogrel, it does not work. Basically, it does reduce the bleeding risk, but exposes the patient to higher risk of stent thrombosis. And there is a borderline also increase in MI in the meta-analysis that we produced. So we have retested a sort of Augustus modified approach. Augustus, they produced recently a very important paper published in Circulation where they do a landmark analysis within the first month and after the first month. In the first month, by dropping aspirin, you are gaining bleeding, but you are exposing patient to a stent thrombosis risk or an MI risk, which is from a magnitude standpoint pretty similar with respect to the bleeding gain. So it's sort of mixed bag. After 1 month, having aspirin on board does not impact the risk of stent thrombosis, whereas keeps increasing the bleeding risk. However, the Augustus studies did not re-randomize patient at 1 month. That is only an observational finding. So the Augustus did not exclude the possibility that this cluster of stent thrombosis simply happens in the first few weeks after DAPT is discontinued, irrespective on when that treatment strategy is implemented. MASTER DAPT is clearly showing that 1 month of DAPT followed by discontinuation of aspirin in the OAC population is not associated to higher risk stent thrombosis. There is some signal of higher risk of stent thrombosis in the study, but that is not coming from the OAC patients. It's actually coming from the non-OAC patients, if you look carefully into the data. So I guess MASTER DAPT is confirming my approach. Sorry, perhaps I'm not very humble in this statement, but I was even before MASTER DAPT giving triple for 1 month. And I think based on the data, this is very justifiable. If I am very concerned about triple therapy for 1 month, and I know I need to drop aspirin, I always test responsiveness to clopidogrel. If the patient is responding to clopidogrel, I let the patient be on clopidogrel. If the patient does not respond, I have a justification to switch over the patient to prasugrel or ticagro. And normally my regimen here is 5 or 60 respectively. Last point that you raised, or perhaps not the last point, the third one.
It was in which patients do you consider to prolong DAPT instead, on the other hand, and which drug?
That is a good point. Many have claimed, look, there is now no room for prolonged DAPT anymore. That would be a wrong message taken away from the study. The study has selected the patients for being HBR. In the HBR space, I think the study is clearly showing that irrespective of the ischemic risk, a shortened DAPT duration is better than a prolonged one. But we did not investigate patients without HBR features. And therefore, I still am very favorable to give DAPT, even prolonged DAPT, to patients in whom the bleeding risk is low and at the same time, the ischemic risk is high. So a 55-year-old insulin-dependent diabetic patient with 3-vessel disease who received 5 stents, I don't see the reason why this patient should not stay lifetime on DAPT. So this patient should stay on DAPT until perhaps a bleeding event happens. If that will be truly the case in the future, once you can implement a reliable P2Y12 inhibitor, that needs to be seen. But if a patient is, for example, stable and you are forced to give clopidogrel, then I would go for aspirin clopidogrel lifelong. If the patient is ACS and you can afford giving ticagro or prasugrel monotherapy, perhaps that is a very viable option. Perhaps that would allow even the removal of aspirin in that high risk setting, but the data with that respect are not 100% already there. So that's something to be seen, which in a way answering your final question, the type of drug to be carried out. We left the investigators free to choose what they wanted. The winner is P2Y12 inhibitor. And in this HBR patient, the winner is clopidogrel, actually, not ticagro nor prasugrel, which is very understandable because the clinicians were more concerned about the bleeding than the ischemic risk in this setting. But outside the HBR space, I would strongly recommend to give a reliable drug. Ticagro, because that has been vastly investigated. Perhaps prasugrel has the same capability, even if we need to acknowledge the data is much limited for prasugrel.
Thank you. Thank you very much.
Great. A couple of questions, Prof, which Alessandro raised was a concept of the stent platform. So what's the applicability of this data and this regimen to other, this was the biodegradable polymer-coated stent, but can we apply and think about this concept and regimen with other stent platforms?
This is a great question, and unfortunately, I don't have any answer because the applicability of the study to other stents is simply unknown. So I can only put my opinions on the table, which is not very relevant. I think the relevance comes from the evidence, and the evidence speaks for this specific stent platform. And honestly, I think we should restrict the result to this specific stent platform. When we do a study with prasugrel or ticagro, we give the rights of the benefits or the risks to either Prasugrel or Ticagrelor. We don't speak about P212 inhibitor. I think we have to approach the stent world with the same philosophy. Each stent is different, is unique because of the stent platform, because of the drug, the concentration of the drug, the polymer, the reabsorption rate of the polymer. So I think this data is ultima specific. That is my takeaway.
Okay, thank you. And we have, let's say, about 5 minutes left. So just one of the things which we would really appreciate as a group of fellows is when you have a clinical question that needs answering, or you have, let's say, a field which has some doubts and there's conflict, when you are thinking about designing a randomized trial, if you could give us kindly like a little overview of how you approach a clinical question and how you approach the design and conduction of such a big randomized trial.
Difficult to tackle that question in 5 minutes. So it's going to be a very long journey. Whatever you're going to do is going to be a long journey. And my journey normally starts because I'm getting old from the feasibility assessment. I never embark myself in anything which I don't think is feasible. So the key point is, where can I find the money to fund the study? That is the key point. And that is perhaps even the most time-consuming part of designing a study. Once you have secured the funding, then everything is getting very easy. You just need to put things in place. Of course, with knowledge, with expertise, with the capability of being surrounded by talented people, because normally clinical study cannot be run by a single individual. It's never a one-man show. But that is the easy part. The difficult part is to put yourself in a position that you can get the study or your idea funded. And that takes a lot of time. You need to build your own credibility in the community, and you need to be able to show the community that if the community invests on you, you are delivering. And that's why my suggestion is try always to go in a stepwise fashion. Don't design the study that you will never be able to carry home. Start with small studies, make yourself an expert in the field, and then you will be growing together with your own studies. But don't make the first jump too high, because otherwise you will fall down.
Okay, I think great advice for the first steps for a lot of us young intervention fellows. So I'll invite the audience, if anybody has any questions about this trial specifically or this field, to please, we have 2-3 minutes left. So any questions from anyone?
Ciao Arif, ciao Marco, I'm Gianluca.
Ciao Gianluca.
Ciao. So I have just a small question.
Gianluca, you don't belong to the young GC Brew anymore. What do you do here?
No, I'm young inside. You will know that I'm young inside as you.
Okay.
So, but I have an important question, because I discussed this question with my fellow. I'm sure that nobody of my fellow will do the question to you. So I need just a brief comment about 75 years old criteria for high bleeding risk. In your opinion, is enough, especially after MI, or you have to put this criteria with additional other criteria, in your opinion?
Oh, that's a great point to be discussed. Let me try to be very concise, because that would require some time for a very blown discussion. So first of all, in MASTER DAPT, only 11% of patients got into the study because of age. So in a way, even the investigators were not very liberal in getting simply elderly patients into the study because of age. They normally add age plus additional criteria. The HBR ARC says age 75 is a minor criteria, so percent does not qualify the patient as HBR. We did an external validation of that concept in the burn PCI registry, and actually we got different findings. We saw that age per se was actually identifying patients in whom the predicted risk of BARC 3 to 5 at 1 year was actually including 4%, which is the formal HBR definition. I did not look into the study with respect to this specific question, so I cannot tell you whether age per se did work in terms of identifying HBR or not. But I'm going to give you a more informative answer based on something that I'm still working on. It's not published. I am merging the precise DPT with the HBR ARC criteria, because we cannot have two different HBR classification, either precise DPT or HBR. Both works in a similar way. If you combine them, actually you have an increased capability of predicting bleeding risk. And so we have created what we call precise DPT2 with this approach. If you ask that specific question to this new bleeding system, the answer is no. age per se does not necessarily qualify patient for being HBR. Yet, of course, if you go very high in the age, such as 90, almost all of them are HBR. But if you take the cutoff of 75, you have 30 to 40% of patients who are not HBR because of age.
Thank you. Thank you.
Great. Thank you very much. So we've just reached time, so I think we'll conclude the discussion for today. So Alessandro, thank you very much. Great presentation. Very nice summary of quite a tricky topic. And Professor Valgimigli, really nothing else to say other than we are really grateful for your time, your insights, and sharing your experiences. I think you really give us a real insight into how to conduct these, how to think about these trials and analyze them. And on behalf of all of us interventional fellows, thank you.
Thank you. Have a good day all.
Thank you. See you all next week. Next week there is no Journal Club because of the GISA Congress. So we'll be back in 2 weeks' time. So see you then.